Good morning, Dr. Batiri. Good morning.
Yeah, good morning, Dr. Adele. The presenter is not yet
Good
online, so
morning,
I didn't
Dr.
allow
Batiri.
people to join.
Oh, okay.
The presenter is not yet online.
Let me call him. Oh.
No, I
Um,
just sent him a message, so I think you try and register and join us.
okay. All right.
Did you go to Mali?
No, I didn't.
Oh, okay.
I know Dr. Idris. He
Yeah,
told
he
me.
just came back. He came back this morning. All right, so Dr. Umi is here, who is the moderator for the session.
Good morning.
Yeah, good morning. We're waiting for the presenter.
Okay. We'll be joining very soon.
All right.
Almost.
Yeah, good morning, Dr. Kalu. Welcome on board.
Good morning, please. Confirm audio, confirm video.
Yeah, audio is on. We're waiting for a video.
Share, let me see, share my screen. Let me share my screen. Which layout am I going to use now? Okay, so let me open up my video. Okay, I think we should use this. Let's use this one. All right, so I'll keep it pending and go back to Zoom. Okay. Please confirm if you're seeing me.
You
Yes,
can see your screen, sir.
screen is visible. Yeah.
Clarity.
Okay,
Very clear.
100%.
Remaining
Audio
video.
breaking. Let me play video and see the streaming, if it is flow freely. Is it flowing
Yeah,
freely?
it is.
All right,
Yeah.
so,
Yes, sir.
all right. Okay.
All right. Good morning, everyone. And it's a privilege to welcome you to the first quarterly webinar for the Young Ophthalmology Forum, this year 2025. So today we shall be having a very interesting topic. And we'll be discussing the topic that's titled Advances and Expert Tips in Cataract Surgery. And we'll be hearing from a man who is well known and has made tremendous advances in ophthalmic practice with emphasis in cataract surgery and anterior segments. He's a known phaco surgeon who has gone ahead to train so many phaco surgeons in various parts of the nation. And recently he was given an award, the national award by the OSN for training in phaco emulsification surgery. So today is a privilege to have in our midst Dr. Anya Kalu, who is a consultant ophthalmologist with FMC Umuahia and a phaco surgeon. And he's going to be taking us through an interesting topic. And we hope by the end of this day, we shall be better than we were before we came into this webinar. So let's make welcome Dr. Anya Kalu as he takes on take us through this topic today. So I can go ahead, sir.
Thank you, everybody. Please, good morning and welcome to this presentation. To be sure I'm not alone, just give me thumbs up, high five if you're there, please. Just a thumbs up on the chat. Drop down the chat and give us a high five. Let me know if you're there, please.
Okay, so before you continue, sir, let me make, please, we'll be taking, you can put in your questions in the chat box. So after his presentation, we'll have to look at the questions and any other thing we would want to look at before the end of the webinar.
Okay, so I have 3 people that have said, okay, how many people that said thumbs up here? All right. Okay, minimum people are giving me thumbs up. Please, I need more thumbs up, more thumbs up, more thumbs up. Give me morale. It's called morale. Give me morale. Thumbs up, thumbs up, thumbs up. Okay. All right. So the next question is, how many of us want to improve our capacity as surgeons, cataract surgeons? How many of us? Just give me thumbs up. Thumbs up. I can see only 2 thumbs up. Oh, 3, 4, 5, 6. Oh, it's not running like water. Great. Thanks be to God. Now I want to welcome every one of us to this webinar. And then by way of opening, what is our topic? Yes, I was told advances in cataract surgery. Now let me burst your bubbles. There are no new advances, but there are better ways of doing the same thing our forefathers in surgery have been doing. Whatever we are finding out now, because we have technology, our forefathers had glimpse of it. So it will amaze you, okay, it will amaze you to know that cataract surgery has evolved back to the very principle of surgery. So we will be discussing every stage. I had discussed with the organizers and I told them it's a very huge topic. Let's pick out one component of it and discuss. We'll discuss it in the principles of it, and also we'll discuss it in the practice of it. So let's talk about SICS. SICS, to the best of my knowledge, might end up being the most common cataract surgery done in Nigeria as of today. And if you know about surgery, you know that your first step in surgery will determine how well the surgery will turn out. Okay, if we have time, we'll talk about another step in SICS. Let's start from incisions. I had done this music and video collection of 10 teachers. I will explain 10 teachers later on. Let me just play this. I'll get to a point and we'll start discussing. Do me a favor, please. Feel free to pause me anytime. I will attend to such questions because every question is an eye-opener. So let me play the video, please. This is 10 teachers. I'll explain 10 teachers, and we are doing incision. This surgery was done sometime, I cannot remember exactly when. Now, this is incision in SICS. Okay. SICS incision is a complex of conjunctival, peritomy, and reflection. A complex of scleral incision and scleral tunneling. And incision in SICS ends in making the main entry wound and accessory side ports. Incision in SICS is a combination of conjunctival peritomy and reflection, scleral incision, and main port and accessory side ports. So someone used to say, whenever you handle the knife, you are still on incision. Even if there's a combination of steps 1 and 2, 3, but as long as you're still handling the knife, it is assumed you've not finished your incision. So let's look at it this way. And then the part I find funny is the scleral incision. Most times you do a good conjunctival peritomy, cauterize, but you put yourself in a difficult, tight corner with a poor scleral incision, with even a poorer scleral tunneling and intracameral entrance if it is not properly positioned. The outcome only God will help us. So let's look at it here. I have already done conjunctival peritomy and reflection. I've cauterized minimally, and I'm about doing scleral incision. Okay, that's what happens. All right. So that was a drama that just happened now. Let's replay that drama again. All right. Watch the drama. Incision, there, and there. Second position, third position. All right. When I want to construct my scleral incision, the best scleral incision, to the best of my knowledge and the ones I've used, is still the frown incision. That means I have an inverted C or a curved C-shaped incision. What that simply means is this. From the very beginning of my incision is farther away from the limbus. The center of my incision, by surgical terminology, the position of the surgeon is decided as the 12 o'clock position. So it is closer to the limbus at the 12 o'clock position. And where I now stop my incision is another end of the C, which is farther away from the limbus. Why is it that way? Number one, it will help give an anchor to the sclera as incised and tunneled. So chances of the sclera incision hooding over or moving away from the point of incision is minimal. That means there'll be little astigmatism. The number two reason why I prefer frown incision is this. By definition, SICS is scleral tunneling. So if you do a frown incision, it will be far easier to tunnel through the sclera towards the right. Right here, I mean one margin of your incision, then to the left, another margin of your incision. So if one is having a straight line incision, that tunneling becomes difficult. You can avulse your anchor position. Now, what do I call anchor positions? Let me show you what I call anchor positions. Forgive me, I'm gonna have to rerun this. Okay, this is this. Fine. This is the beginning of my incision. And let's divide it. This is 12 o'clock position, if I'm correct. The eyeball looks like it's rotated. So assuming this is 12 o'clock position, if I am actually right here. Can you see my cursor, please? Give me thumbs up. One person should give me thumbs up if you're seeing my
Can see
cursor.
it, sir.
All right, so this is 12 o'clock position. So from 12 o'clock position, this should be about 1 o'clock position. This should be about 2 o'clock position. So my incision is starting from 2 o'clock position. So 2 o'clock position becomes the first anchor. I go back to 12 o'clock position here. Then 10 o'clock position becomes the last anchor position. So if it is a frown incision, that means it curves farther away from the limbus at my first point beginning the incision, comes close to the limbus at 12 o'clock position, and moves farther away from the limbus also as I finish my incision. Then what I've just done is this. I've given myself room to tunnel the sclera into the clear cornea as far extensive as it can be. Imagine if I just made a straight incision. Let's just say they are all equidistant from the limbus, both at the beginning and at the end. When I'm doing the tunneling, I have already put myself in a tight corner and I might avulse this anchor position. If you avulse this, that means when you're done with the surgery, you might have to come and put suture here. So you would have done your SICS in principle, but you did not do SICS. All right, so let's play the video out and see. Okay. Now the tunneling now starts. Scleral incision done, tunneling starts. How do you tunnel? Okay. First, I now did this. The anterior margin or the anterior lip of my incision, I now have to escort the crescent blade into it. What am I looking at? Hold it. Good. I have to do that tunneling. Number one, to achieve a plane of tunneling. If the plane of tunneling is too shallow, you might likely buttonhole the upper scleral half. If the plane of tunneling is too deep, you might have early entry into the intracameral space. And sometimes you might actually do a true and true incision and the knife is already into the vitreous cavity. So that is the importance of that creating the lip of the anterior incision margin. How deep should it be? Textbook says 300 to 400 to 500. All right, there is no caliper to do those measurements. Some people say 1/3 above, 2/3 below, 2/3 above, 1/3 below. Well, I am wondering how a new surgeon who is just starting a career in cataract surgery will know what is half of scleral tissue above and half of scleral tissue below. So the best way, which is fairly, or let me just use the word, relatively standard across the whole world, is the tip. Please, could you kindly watch my cursor here? Could you please give me a confirmation, please, if you are seeing my cursor?
You can, sir.
All right. It gives me morale if I'm not alone in this matter. Most of all, thank you very much. I'm grateful. So you now see this crescent blade is beveled. And you may not have all crescent blades beveled. Please bear that in mind. I know Arcom products may not necessarily have this bevel. So just be careful. If you're in charge of your purchasing system in your environment, okay, ask for ones that have bevel. If you don't have bevel, you can now use your initiative. That brings me to the next thing I'll say later on before we finish this part of tunneling or initiating a tunnel. So this crescent blade is just adequately deep enough to give me a safety depth. Let's do it again. All right. Okay. Watch is the incision. All right, good. Now watch the excursion into the anterior lip. Fine. Immediately I get to that place, I stop. Immediately I get to that place, I stop. That's the bevel in, the ridge, I now stop. Fine. I've gotten my plane. That is one way of getting your plane. The other way of getting your plane is, number one, if you can hold it. If you cannot hold it, then look again, something is still not right. And if I now hold it, I take an obvious physical look. I'm still the surgeon in charge of operating. I'll now pick up the scleral flap, which is anterior that I have just made now, and I lift it up and I make my judgment. Do I have safety sclera below? I must answer that question before I proceed. Do I have shallow sclera above? Do I have a safe sclera above, sufficiently above, and sufficient sclera below? If I can convince myself that I am safe, I will now proceed with the tunneling. The reason is simple. If you are having a superficial scleral thickness and you continue that way, you buttonhole it. And if you buttonhole, the adrenaline surge will continue. And I hope you realize, please, how many of us are surgeons here? If you're a surgeon, please give me thumbs up. I am one. If you're a surgeon, give me some thumbs up, please. I want my chart system to be, most of them be zeroing out all these charts. The older ones, let me see the newer ones. Who is a surgeon here? Please give me some thumbs up because I'm a surgeon. All right. How many of us are authorized to have apprehension? I'm authorized to have apprehension. I'm a surgeon. That's the hallmark of every surgeon. We're all apprehensive. So if you have never been apprehensive, please, you're not a surgeon, put your hand down. But for some of us who are surgeons, we're authorized to be apprehensive. So if you have been apprehensive before in your career, please, that means you're a healthy eye surgeon. All right. But then the key word of being an expert eye surgeon is how you can control that apprehension. Put apprehension under check. So tell the adrenaline pumping system to calm down. Hey, be calming down. Adrenaline, be calming down because I am walking. Why did I say so? Because if peradventure you buttonhole, adrenaline pump will increase times 10. If you have early intracameral entry, maybe the tunneling was too deep into the sclera, what you're going to find out is this: iris will come out, anterior chamber will shallow, then apprehension will also set in. And usually, which is unfortunate, we used to give white cataract to residents. Give it to residents. I have done that before, so I apologize to all my residents in those days, and I don't think I will ever commit such a crime again. To give a white cataract to resident to operate. White cataracts are just deceitful on themselves. So giving to somebody who is not yet experienced in cataract surgery is not, after all, a wiser decision to take. So if you have early entry, it will be difficult to reclaim your plane of work. So let's go back again and just a little more revision here. Mustafa, please let everybody type 424 for me. Please type 424, 424, 424, 424. All right, so let's start this. I think with this introduction, I can proceed. Type for me 424 and ask me what is 424, and I'll tell you this is the first 4 millimeters from the limbus. So are you starting your surgical career for the first time? Get yourself a caliper. Measure 12 o'clock position where you are, extend it to 1 o'clock, extend it to 2 o'clock position, and from the limbus, map out 4 millimeters. Get trypan blue in a cannula. Make sure the trypan blue is coming out from the cannula tip and mark 4 millimeters on the limbus at 2 o'clock position. That is 4. The 2, which is 2 millimeters, is from 12 o'clock to the bare sclera. So you use the tip of the cannula with trypan blue on it and make a dot on the 2 o'clock position. Then as you now go to 10 o'clock position, you use also caliper, map out 4 millimeters from 10 o'clock position to the bare sclera and use the cannula with trypan blue and dot again. So you now have a dot of 4, 2, and 4. You can now use your hand freestyle with any blade you like. Some use knives, some use Christian blade, some use sideboard, some use razor blade. Also some use size 15 bar packer blade. Whichever one that's available to you. Just join from the first dot of 4 millimeters in bare sclera, join it to 2 millimeter by 2 o'clock position, and then freehand join it back to 4 millimeters. So you give yourself a good frown. Now with time, you can even make your own 5, 2, 5 if you do choose. You can make your own 3, 2, 3 if you do choose. But whatever gives you that freedom and flexibility in doing your work. So that is how to get your scleral incision. And then we'll go to scleral tunneling. So let's let this say 4, approximately 2, I'm going back to 4. So I've done my 4, 2, 4. Okay, I advance the Christian blade into the anterior lip up onto the ridge for safety reasons. For safety reasons. All right, so I've gotten enough safety. Anything beyond this, I can perforate. I can now hold and stabilize. All right, so let's tunnel. Gently, gently, and gently, and gently, and gently, and gently until clear cornea. Now, why did I stop? Everybody type for me, tug. Tug is a physics word. T-O-R-Q-U-R. Q-E, sorry. Tug. Tugware. T-O-R-Q-U-E. Type for me, tug, 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 tug it out. For those who are fast fingers, please. If you're fast fingers, do me a favor. Go to your ChatGPT or your browser and check out tug. Tug, 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 tug. Tug it out, tug it out, tug it out. It is T-O-R-Q, not G. Tug, 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 tug. Oh, fine. Check out what tugs, please. I will tell you why I stopped the tunnel in there. Tug. Has anybody found out tug? Copy and paste, please. Fast fingers, fast fingers, fast fingers, fast fingers, fast fingers, fast fingers. Copy and paste. What is tug? Tug is a measure of force that can cause an object to rotate about an axis. Rotational force. Good. I'm grateful. Thank you, thank you, thank you, thank you. All right. In cataract surgery, for Christ's sake, what is this rotational force? It is called wobbling. It is called wobbling. So let's do this again. All right. So, Mustafa, please watch what I'm doing. There's no wobbling. There's no wobbling. That's why the knife is cutting. It might look like I'm not doing anything, but now wobbling now starts. Why is it wobbling? Why is it wobbling? The law of physics. I will explain that. I stopped that motion there because it was wobbling on me. It was becoming like what they say in physics, no work done. So I now went this way. Why is it not wobbling on this side? I will explain later. All right, so I'm tunneling, targeting towards 3 o'clock position. But now scleral tunnel. Let me bury. Okay, my crescent is buried in a scleral tunnel. Imagine if I had made initially a straight incision, I would have avulsed that 10 o'clock position anchor. I pray you understand what I just said now. SICS by definition is a scleral tunnel. You deliver the nucleus through a scleral tunnel. So I have created my scleral tunnel, but my anchor is safely intact. That anchor will not allow me put suture. That anchor will not allow that wound to retract and give me undue astigmatism. This anchor will even allow me some good finesse during the cataract surgery proper. Now you can't see my crescent blade because it is within the scleral tunnel. That is how the cataract also will come out, within the scleral tunnel. And I can promise you, you may do 100 SICS and you will not have one, not even one iris prolapse, because it's an abnormality to have iris prolapse. I don't know if I'm saying the right thing, but I think I'm saying the right thing. It is an abnormality to have iris prolapse. Whenever you have iris prolapse, copy that surgical video, come back and play it back again. You will see what you did not do very correctly. I promise you that. I've reviewed most of my videos, and sometimes I'm even ashamed I do some surgeries myself. But that's how I learn. That's how I get better. So this is the scleral tunnel, and I'm targeting the scleral tunnel to move from, confirm my arrow at 2 o'clock position, confirm it now at 1 o'clock position, confirm at 2 o'clock position, which is where I left the conjunctival peritomy. Have you seen this here? Confirm it heading towards 3 o'clock position. I don't know how far I went. 3 o'clock position should have been somewhere here, if I'm correct. Yes. I don't know how far I went, but just to give you some perspective of what I mean by scleral tunneling. So my incision stops somewhere here, but I am already tunneling inside and peripheral as possible. So there is no amount of nuclear density that can never come out from this incision. Right, so let's continue this thing. Why? Hold on, something happened here. I just saw something now. So most of our place, watch this, watch this, watch this, and watch this. I want to show you something now. All right. Look at the cornea if you can, please. You will see the Purkinje corneal light reflex. That is my guide in knowing when the eye wobbles. Because my concentration, or rather my attention, should be at the place of action, my surgical instinct spans through the whole view of the eyeball as illuminated by the operating microscope. So I'm looking at the Purkinje corneal light reflex. It's guiding me in my operation. To cancel out the effect of torque or wobbling, in the law of physics, the support system and the point of action, the distance between them will be short. Imagine, most of our place, could you hold your hand at the elbow, if you can, please, at the elbow, and see if you can flex it. If you see, it's so free. You have a very long part of your hand from the elbow to the fingers. They are still mobile. But if you go midway and grab your hand, it's difficult to flex the whole arm because you've already frozen motion there. Should you now go closer to the fingers and you're working at the fingers, there'll be very minimal work. So to minimize the wobbling of the eyeball, the best thing you could do is to hold support with a colibri very close to where you're working, and the eyeball will wobble less. If it is wobbling less, then that sharp cutting knife, I will assume nobody here recycles crescent blade. That sharp cutting crescent blade can now cut effortlessly. The whole of scleral incision and tunneling can happen within 1 minute. I'm trying to say that it can be that effortless and fast. Let's look at this. Okay. I now have to grab closer. Have you seen now? I left this part because it was wobbling on me. I was doing no work. So have you seen? It's still wobbling, but wobbling less. I shortened the distance between position of action and the position of support. So I'm done with conjunctival peritomy and reflection, and I'm done with scleral incision and scleral tunneling. And what I would have done there, which I think I did it, that was creating my main port and side port. Because I would have stained with trypan blue, so I left those ones. But we'll look at them later on because I think there's another video. This video, I got it from Mohanta Pradip, where he was teaching SICS for new residents. I tried to get a better quality of it, but let's play it and see what he did here. This is not my video, it's Mohanta Pradip's video. To help him stabilize, he did superior rectus. All right. That's how to grab superior rectus, please. If you're in doubt, take a measurement, take a caliper and measure. Anything 7 to 8 millimeters from the limbus, you can grab effortlessly. I'm not a fan of superior rectus. The reason why I'm not a fan of superior rectus bridal suture is because of I've found a way to stop tug, the wobbling of the eyeball. So if you can convince yourself with time and you can stop tug. And let's watch what Mohanta Pradip did here. He mapped out 10 to 2, 10 to 12, 10, 12 to 2. All right. To avoid wobbling, what is he doing? He's holding. Position of hold is close to position of incision. So no matter what you do in this surgery, it will never wobble. That is one thing I'm trying to say. Position of action, position of support should be close to each other. Tug will be cancelled out. All right. So avoid walking, assuming you're walking at 10 o'clock position, there is no wisdom in supporting at clock hour so far. So another guide to know your 10 o'clock to 2 o'clock position is conjunctival peritomy. But you can now tunnel freely. That's another guide. But for now, just use your trypan blue to mark. It will help you. With time, you no longer need marking. You now start doing freestyle. So for a surgeon that is beginning to do surgeries, please welcome to the club. Do not be confused. Don't be scared if your hands shake. Dr. Anya, my hands still shake. So it is healthy. But when I'm done with surgeries, even myself, I'll be clapping for myself. But nobody knows that it is part of being alive to have shaking hands. So let's look at what he did here. He's on 4. Have you seen that? 4, 2, and back to 4. Fine. All right. So what he now did here, is not recommended by me. If you do it the first time, it doesn't help you, please be careful with the second incision. It might go deeper than you planned. So this is his own tunneling, going in with the crescent blade into the anterior lip to get a good plane. Now, this is Mohanta Pradip. Mohanta Pradip has been, he qualified as a consultant 26 years ago. Added to how many years of residency? So Mohanta Pradip has been in ophthalmology for more than 30 years. Don't do this at home. Don't wiggle at home, and I will explain. I've seen fellow surgeons wiggle. Now look at it here. Look at what he did here. Can I pause this and show you something? Let me pause and show you something. All right, so let's do this. Don't wiggle. Mahanta Pradeep is doing this because in India they produce knives. In Nigeria we do not produce knives, so we are still a little way below some certain things. All right, so let me leave it at that. Look at his incision here. Follow my arrow. You see where he stopped his incision here. Mahanta Pradeep is highly experienced and so skilled, so he can maneuver this little space between here and here to do a scleral tunnel up onto a desired position. Please do not try this at home. Mahanta Pradeep's incision, the anchor point started probably 3 millimeters. This is probably 3 millimeters compared to 2 millimeters at the focal position. My advice is this: make your own 2 millimeters at 2 focal position and come down here. Come at 4 o'clock position. You can even come at 5 o'clock position. There's no harm in that. Come at 5 o'clock position so that you can have this wide space to do target practice on how to tunnel the sclera. Okay? So for those who do target practice with animal eye, please give me thumbs up. Target practice with animal eye. Target practice with animal eye. Give me some thumbs up, please. For those that will do target practice with animal eyes, maybe any animal eye you can find. Give me some thumbs up, some thumbs up, some thumbs up. All right, I think I'm alone here. All right, no problem. So for those that will do target practice, yes, you can start with 5 millimeters from the limbus to start your anchor. Go to 2 millimeters from the limbus at 2 o'clock position and go back to 5. So you can have space to do this scleral tunneling. This will be difficult for me to do, so I wouldn't even go for that. So I use 4-4 dimension. This is practically 3-4 that you did there. All right. Let's say video sutures. Let me comment on that. Because I have been, it's like some people that don't cauterize. Mahanta Pradeep does not cauterize when he's not teaching. But when he's teaching, he does his cauterization. So many people don't cauterize because they have found their plane. But I'm wondering, somebody who is just starting his career in cataract surgery, please use video suture, please. And that is why I brought this up to show how video sutures can be used. We'll discuss video sutures, please, if it comes as a question. But it is standard practice to start well. Start without the eyeball wobbling on you. All right, thank you very much. Let's continue Mahanta Pradeep's video. Right. If you watch the full video of this, you will discover that he's trying to let you know you should not have voiced that. That's what he was saying. I knocked off the audio. See what he's doing? That's a skilled surgeon doing that. Please do not try this at home because you might have voiced that. If it's avulsed, that means you need suture to anchor it back. There's so much wobbling. Now, though you might use bristle sutures, there's still wisdom in using your supporting scleral forceps or connectoral forceps to support. Minimal wobbling is almost like guarantee to effortless work. Fine. He now does his accessory side port. It's advisable that you should start learning how to do double accessory side ports. Okay. This is my surgery. Okay. I think I did this one sometime last year. That's what this. I grab for stability. And when I grab, I pulled it up. Please, can I show it back again? Somebody asked me how I do, I think it was in 10 teachers, one of these 10 teachers. Somebody asked me a question. I grabbed and I pulled it up. I just pulled it up because the eyeball is fastened to the orbit by all structures, all of them. So when I tug it up, it's going to minimize wobbling at least to a very fair and reasonable distance. So let's do this again. So I tugged it up All right. So I'm picking both conjunctiva and tenon. Okay. I will grab. Any tenon that's above, I pick it up again. All right. My point of support is usually very close to the point of action. The reason is this: tug, minimize wobbling of the eyeball. The grab. So at each one time you're holding at most conjunctiva and tenon together. Okay. So that was my conjunctiva peritomy and reflection. I'm not sure I cauterized it. Okay, I do not. Now my 4, 2, 4. All right, let's look at that here. Let's look at this. Incision length, tunnel length, 2 words or 2 activities you have to do. Incision length is how long is that incision. Most people target 6 millimeters long incision. I used to do that until I found myself in a very tight corner one day. I underestimated the density and size of the nucleus. So it became a tug of war and I lost the capsule. So I don't know how far back that was, but since then I learned the lesson of making your incision length a little bit longer than you will finally end up using. In the event I need to expand, in that time the eyeball is soft, it will be easier for me to just make a 1 millimeter extension to the right and a 1 millimeter extension to the left. So deliberately, I make my incision longer than I will use immediately. So I target 8 millimeter incision, but please, I will not use all 8 millimeters until there is need. And those needs usually will occur when I deliver the nucleus into the anterior chamber. So the incision length is what you just seen now. I deliberately made it longer. Montapardi made his own 6 millimeters. That's why he was using the keraton to point dab at that position, avoid this place, avoid this place, avoid this place, because you could avoid it. But now I have probably plus or minus 4 millimeters, if I'm correct. Yes, 4 millimeters. Then 2 millimeters at the limbus and another 4 millimeters here. So I have 4, 2, 4, which is safe enough for me to tunnel under the sclera. So let's finish up there and see what happened there. So I now looking at the tip of my crescent. When the tip is buried deeply, I now have achieved adequate depth. Before I end up, if I'm not teaching any residents or anybody with me, I don't bother cauterizing because I know my plane. Anyone who see me cauterize, you know that somebody was left to be taught. So I'm trying to do that for the whole length of the 8 millimeters I did that initial incision. But when I now start the surgery, I will use 6 millimeters. If I now need to extend, it will be easier because at that moment the eyeball is already soft. Can I hold? Yes, I can hold. That means I have adequate depth. I now start tunneling. So wiggle into the anterior chamber is not safe. It's better you, first of all, tunnel about 2 clock hours and find some space. If you miss your plane, you can confidently go back to another zone and continue from there. Even if there is early intracameral entry, no problem. We pressurize the anterior chamber with viscoelastic solution, start all over from another plane. Because of wobbling, I have to regrab. So a point of action and point of support are close to each other. So the knife can now easily cut. And trust me, it's really easy and refreshing if every effort you put gives you a corresponding response that you want. So I'm done. I track it. Now, because I have done adequate scleral tissue above and saved scleral tissue below, I can follow that plane and cross in any direction I want. Support again. Somebody should ask me a question. Why 2 millimeters from the limbus? Please start the question for me. Why 2 millimeters from the limbus? Type question for me. Why 2 millimeters from the limbus? Okay. All right, so I've made my side thoughts. This was a traumatic cataract. As expected, everything can be wrong in this case now. So I had to use the trypan blue to stain. All right. Because I was anticipating everything to go wrong in this case. At this point, please, let me make a disclosure. My irrigating fluid at this point is a diluted adrenaline. 1 ml of adrenaline plus 9 ml of saline. So it will help me blanch all the bleeding. Before I now finish my capsulorhexis, you will not see any bleeding anymore. So please, that's a disclosure. So that is a diluted adrenaline I'm using to infiltrate the tunnel. It will clean up the blood that has got into the tunnel. So by the time I finish the intraocular manipulation, for example, capsulorhexis, by the time I'm done with capsulorhexis, all I will now find is a quiet eyeball. Okay. So in principle, we can say that incision in SICS is over, but we are surgeons. We have left the anatomical eye in a non-anatomical state. Why? Because the anterior chamber is shallow here. So incision, well, it outlines the extent of tunneling. If you could see, somewhere down here, extent of tunnel is somewhere here, and extent of tunnel is somewhere here. All right, so because it was traumatic cataract, I needed to be sure that there was no vitreous in the anterior chamber. So repressurize the anterior chamber with viscoelastic solution. Anatomically and physiologically, we have reformed the eyeball. Fine. And this you can now say that incision is over. Okay. Thank you, everybody. Let's rehearse incision. Somebody asked a question. Let me see the question I wanted to be asked. What are the effect of the tooth forceps on the anterior lip or the okay, what is the supporting hole or is streptopharynx? Thank you. I'm just for that question, please. Okay, so let's look at it this way. Incision in cataract surgery is a complex of 3 things, actually 4 things. Number 1, conjunctival peritomy and reflection. Number 2, scleral incision. Number 3, scleral tunneling. Number 4, main port and accessory side ports. So those are the ones that constitute the incision in cataract surgery, sorry, in SICS. And then physiologically, you have to reform the anterior chamber back into approximate anatomical components. To achieve good incision, number 1, mark your 10 o'clock position to 2 o'clock position and do your conjunctival peritomy. Now, if you're starting, it's advisable, extend it beyond that so that you can have space. Number 2, to make a good scleral incision, please, I prefer the 4-2-4 approach. Some use 3-2-4, sorry, 3-2-3 approach. And when I say 3-2-4, please, it happens. Some people do that. And I will discuss that as part of the complications of a wrongly positioned incision, which is very obvious oblique astigmatism. But if we use 4-2-4 or 5-2-4, we'll have adequate space for tunneling. 10 minutes more. All right, so this is 4, this is 2, and this is 4. Probably this is actually 5, 5-2-4. So 5-2-5, please. So in the process, you can now have a good frown incision and have adequate space for scleral tunneling. And when you now achieve adequate depth, you can now grab the lip And that brings me to that question. When you are holding the lip, you're not crushing on it, you're just supporting it. I don't know how else to do that. But if you can just pinch yourself without wounding yourself, that's how it is. If you can use your finger and pinch yourself without wounding yourself. So that is how I do that. The standard thing is this: use a non-tooth forceps. That I was saying initially, some of us don't have the privilege of determining our purchasing system in our hospitals. So it's possible the one that will give to you might even a serrated forceps that will even do more crushing. If you have the privilege of being purchasing by ourselves, then please, the standard instrument to use is a non-tooth forceps. And again, even if you're using a non-tooth forceps, just imitate holding yourself without forceps without injuring yourself. That's how it is. So you could see me use a tooth forceps and you will not see a buttonhole, or it will not avulse outwards. Then you tunnel into clear cornea. The textbook says 1 millimeter to 1.5 millimeter into clear cornea. So in all, you have a tunnel length of minimum 3.5 or 3 millimeters tunnel length from exterior, beyond the limbus in the sclera, 2 millimeters, and into clear cornea, 1 millimeter or 1.5 millimeters. So you have a tunnel length of 3 millimeters or 3.5 millimeters at the focal position, and obviously a longer tunnel length at the anchored 2 o'clock position and then 10 o'clock position. Oh, wow. Thank you very much. I think so far so good. That will be all for the incision. Any questions? We'll take it from there. Thank you. Mustafa, please.
Thank you very much, sir, for well-detailed explanation on incision making for cataract surgery, SICS. So I don't know if we have questions to ask the surgeon, the anchor person for today's discussion. You can type it, or you can also unmute your mic to ask questions. So I want to ask, can questions be asked on other steps aside the incision you just discussed? Because I think there will be more questions on other steps which were outside what you just discussed this morning.
The answer is a capital yes. And please, could I just say this? If you have time to join 10 teachers, usually we'll be discussing this. Incision for cataract ICICS, usually we took out 2 days, if I'm correct, to discuss only incisions. So we had time to look at every practicability. For example, okay, I missed out something. I mistakenly said 3, 2, 4, and it felt like a mistake. It was not a mistake. Some people do that incision where your incision is in some parts of the eye. It is not equicentered. What do I mean by equicentered? It's a word I just conjured myself. I have not seen it anywhere. Equicentered, I mean, if you map out 12 o'clock position, it should be the same center from 12 o'clock position to the right and 12 o'clock position to the left. If you decenter it, you have oblique astigmatism afterwards. And the reason why most people don't cauterize is simple. If you can use fluid to find your direction, please use, but for beginners, please cauterize. Every form of cauterization has been proven to have some level of increase scleral clarification. So to avoid scars on the sclera, no matter how minimal they might be, most people don't cauterize. Just use adrenaline blanching. All right, please. Thank you very much. Any questions can come up from anywhere, so we can have time to talk about it. Of course, it will be a brief discussion, but it's still a question, still an answer. Thank you.
Okay, sir. So I don't know whether you were able to answer the question you asked them to type on the chat box, why 2 millimeters at 12 o'clock?
Okay. 2 millimeters is a standard discussion from the textbooks, from the limbus, 2 millimeters. Some say 1.5 millimeters. But I tried a little experiment. Nobody sent me, but I did it myself. I took my time, took a caliper and measured my crescent blade. In those days, there was this particular type of crescent blade they used to deliver to us. I discovered actually the crescent blade from the widest diameter to the tip. I was getting approximately 3 millimeters. So in my random thoughts, I was like, could it be why they say 2 millimeters from sclera to limbus and 1 millimeter to 1 millimeter from limbus to clear cornea. If you ask me, I don't know. I was just curious, and I made that discovery. So what if it is the reason? I don't know. I can't tell. But one thing that is standard surgically is this: if you have a long tunnel length, it is practically impossible to have iris prolapse. It's practically impossible because when the nucleus is delivered, the tunnel will close on itself, a position of the tunnel. So there's no how anything can come out. So
Thank you very much,
that's why it is 4, 2, 4. The 4 is moving it away from the limbus to give you adequate spacing for your scleral tunneling. Imagine after surgery now, the flap is up and down, moving up and down, that you require suture to come and put. That means even you're not happy to yourself. Oh, thank you.
Okay, sir. Thank you very much, sir. So you could still do to put in your questions in the chat box. So, sir, I wanted to ask, aside the incision making, how can one conveniently change or convert from can opener to CCC, seeing that there are some cases you might not use can opener for, like the white cataract you mentioned, it's going to be quite difficult to do that. So how can one, because one might want to start or to convert to CCC when he has not actually done it before and he's trying to learn it outside of the eye, is there any way someone can do that?
Okay. There was a time it was persuasively advised. It was so persuasive that it became more like a commandment that residents should be involved in wet labs. At the time, I even asked my residents to please own a wet lab in your house. And the whole reason is this: you can test run everything you want to test run without damaging someone's eye. I'm standing here to regret spending all my career as a resident and early time practicing alone doing can opener. Can opener because you can never see the margin of your rexes. Sometimes it even retracts beyond your view and iris will cover it up. Because of that, all my life as a resident, I never for once passed a capsular tension ring because I was not seeing anywhere to pass it. Number two, I never passed a capsular tension segment because I never had opportunity of seeing a capsule to put it. So I took that decision to make sure that I started doing my continuous curvilinear capsulorhexis on the anterior capsule. And that was when I now started doing all the tension ring and capsular segment to pass. Now, when I hear the word convert from can opener to CCC, I feel a little funny. Forgive me, just personal. I'm like, why can opener even in the first place? I think we are going to a robotic system now where every teaching of a younger surgeon should be anterior curvilinear capsulorhexis. So I don't know how much time we have. I don't know how much energy we have. I could just say, let's talk about CCC, how to perform a CCC. And if you can, please get yourself a loop. If you cannot get a loop, get your trial frame, inoculate +3 or +275 into the trial frame and wear it. Have your child hold a torchlight for you in an animal eye and stay in your house. Simulate a wet lab in your house. Yes, that's what I'm trying to say. So if, for example, we discuss this now once within this space of 45 to 50 minutes, you could do like 20 more before the end of today. So that whatever you discuss now, by tomorrow, you're already a master in it. That is the concept of 10 teachers. You have 10 videos, grab 10 videos, edit out only the incision components, merge them together, zoom the area of interest, and then create your own video. So each time You can never say nobody taught you. No, it's not true. The sources and the materials are all out there. That is the whole concept of 10 teachers. And if it's okay about you, I
Yes,
think
sir.
we'll speak about
Yes, sir.
maybe
Thank you very much. Maybe we would plan for that maybe some other time, as we don't have such time at the moment. So there's a question here in the chat box that says, please, how can I avoid exerting pressure or pressing the globe, especially when inside the anterior chamber?
All right, look at it this way. When you are doing your CCC or you're manipulating into the anterior, you're manipulating in the intracameral space. As a surgeon, your gaze should be a panoramic gaze, but your focus should be at the area of action. Two things are in my mind. Number one, visco will come out initially and should stop. That means I'm not throwing down this hand, depressing this hand. I'm only moving my fingers, only doing the job I'm supposed to do. My supporting colibri should not dimple the eyeball. So if I notice the anterior chamber is shallowing on me, that means I'm losing compression, I'm losing the visco out of the eyes. And there is no magic to it. It is the surgeon that is doing it. Either you're dropping your dominant hand you're using to do the maneuver, maybe rexis or nucleus management, or your supporting hand, which is holding the colibri, either you're dimple or dimpling, whichever one, I hope it's correct English to say dimpling, into the eyeball. So you now see two things are happening. One hand is dropping down, pressing down on the posterior scleral lip, while the other hand is dimpling into the eyeball. You are now compressing the globe, so visco will be coming out. The movement of visco is one way of knowing that there's undue external pressure in the eyeball. So if you're manipulating anything in the anterior, in the intracameral space, and the AC is shining on you, and you're putting back visco again, please remember, it was surgeon induced most times, not necessarily patient induced. Apart, patient doesn't even know what's going on. So that means you have to reassess your hand coordination. There's what they used to teach us in FICO in those days, finger walk. Okay, maybe we'll talk about that if there's any room for CCC. It's a whole lot of curriculum on this. Thank you.
Okay. So thank you very much, sir. So finally, sir, because of time, you made a comment that you will never give or let a resident operate a white cataract. So seeing the complications that follow white cataracts, especially the intracapsular pressure, Argentina flag that comes up when doing your capsulorhexis, and maybe sometime while making a side port, the anterior capsule can even give way and all that. Is there any tips you could just give us on how to manage a white cataract briefly, sir?
There's no briefly component to managing a white cataract. First thing first is this. Go to the center. Okay, let's start from the incision. Make sure you have a safety margin of incision. Your minimum, to the best of my knowledge, should be 4 to 4. Make sure you are well into the clear cornea, at least 1 millimeter into clear cornea, so that you have a minimum tunnel length of 3 millimeters from the limbus. From the scleral incision at 12 o'clock position. Then in making the side port, you don't have to introduce the full length of the 15 degrees blade into the eye, because when you do that, the aqueous will be lost. And if you keep introducing the blade, the tip will puncture the capsule. So go through a minimal keratom entry. When you put your keratom, the widest diameter of the keratom should not be put in at the same time. So the main port, if you're right-handed, I position my main port between 12 o'clock position and 11 o'clock position. For those who are left-handed, they might adjust a little bit between 12 o'clock position to 1 o'clock position. But if you are using 3.2 millimeter keratom at this widest diameter, A Swiss means just advancing only 2 millimeters and then leave it. Then go and make a central puncture following the Purkinje corneal light reflex. Just puncture it and see it. And see if it is clear, milky fluid that comes out. If there's no milky fluid, then pause and hold. Fine. With that, you can now make the second decision. If there's milky fluid, go back in with a Simcoe and aspirate it out. When you are aspirating it out, please do not direct the flow of the fluid into that opening. If not, as you're aspirating, the fluid is refilling the bag again, and the high intralenticular pressure you're trying to decompress will always decompress, refill with your fluid, you decompress it again, it will refill with your fluid. And as you're coming out with your Simcoe, you come out on the aspiration mode. So in case there's any fluid that has gone into recompressing the intracapsular bag, at least you get it out as you're coming out. Then if you need to irrigate, go behind it so that you don't refill it up as you're going. I think we're already discussing CCC. It's a longer thing to discuss here. But the thing is this, it's not wise. In those days, they used to throw white cattle on residents. I don't know why. This is not wise. I think we should give residents something that they can manage, learn when they are comfortable, and they cannot move the Argentina flag. Argentina flag sign, to avoid it, it's like a textbook on its own. All right, Joe, thank you. Maybe CCC, we'll talk about it later.
Okay, sir. Thank you very much. So someone asks how they could access the 10 teachers, as you mentioned, so as to follow up with the training.
All right, so let's do this way. I'll make a publication on OSM website, and then I'll send to Bature so that it can be also published in a Young Ophthalmology Forum. 10 teachers is only it's just when we start discussing steps in cataract surgery and basic tips and practicality, not necessarily quoting textbooks, practicality of doing those things they said in textbooks, so we can get it better. Done 10 teachers in November, 10 teachers in January. February is a resting month for me. In March, also there'll be 10 teachers. Apparently, because of this, I can even organize the 10 teachers by next weekend, so we can talk about CCC, if it's okay by us. And then also there are 10 teachers for trabeculectomy too. But my advice is simple. If you can get animal eyes, if you can, please get a wet lab in your house. Forget the hospital wet lab. Get your own wet lab. Have a video. Set your camera. If you have an iPhone, better. If you have a Samsung that can zoom from a distance, better. Then zoom in what you're doing. After that, come and watch it. If you send to me, I can criticize it. Send to Bature. Bature will make it available to me, and we can criticize and then guide from there. The whole essence is this. If there's a mistake done for one surgery, it shouldn't repeat in the next surgery. That is what makes you better. 10 teachers simply means I'm learning from 10 surgeons at the same time. So I am a component of all the good things of all the 10 surgeons. So you will become better than all your teachers. That's what it means. 10 teachers. Thank you, everybody.
Right. Thank you very much, sir. It's quite a pleasure having you with us this morning. Thank everyone who has joined. Dr. Bature, do you have anything to say?
Yeah, thank you so much, Dr. Anya, for the beautiful presentation. On behalf of YOF, we sincerely appreciate your insightful presentations, especially the video demonstration on tunnel construction. It was not only detailed, but very practical. It's I believe, it's an invaluable resource for young ophthalmologists striving to enhance their surgical proficiency. So we say a big thank you, and we look forward to having you another time on our fortnight presentations and webinars. Thank you so much.
Thank you, sir. So we've come to the end of today's